And for some context, I'm Majorac. Starting in the current year of estimation for GBD 2020, I'm the team lead for the reproductive, genitourinary, and digestive disease disorders team, which includes our hepatitis, our hepatology topics. And I've been at IHME for a couple of years now, and last year was also involved in the hepatitis burden estimates for GBD 2019, which is what I'm presenting today. I'm part of a broader team that includes modeler Brittany Sheena, who's on the call today, and Jonathan Kokarnik, who is our primary cancer modeler, our team leads for cancer estimation and causes of death data prep, Lisa Force and Mohsen Nagavi, and all of the preceding teams. GBD is an iterative project, and so we're always building on what came before, and Theo Voss was our leader last year on these topics. I'm going to go over the methods used to estimate mortality related to hepatitis C and GBD, talk about some of the changes in the methods between GBD 2017 and 2019 in particular, and then and highlighting some of the expected changes in the results between GBD 2017 and GBD 2019. Those results were released to the public this October, and I have a link in the slides to our GBD 2019 page, which has access to all of our data inputs, our code, our visualizations of outputs, so, as well as papers sort of interpreting and integrating those components. I'll briefly remind you that modeling decisions for HCV-related mortality in the GBD are shaped by 8 principles that are used across the GBD, including the production of comprehensive comparisons. So we don't only produce estimates for those places with adequate data to produce very certain estimates. We leave no blanks for any of the countries, age groups, or that are included in the GBD, or for either sex. But given that, that means some of our estimates are highly informed by data, and others are rely much more on assumptions and regression approaches. So we always try to communicate the strength of the evidence. We try to make sure that our estimates are internally consistent, so that all deaths due to all causes have to add up to our all-cause mortality estimates. And given the diversity of data sources that are differences in the data sources used for those things, sometimes that actually requires a lot of decision making. We make an iterative approach to estimation, so we produce results annually, updating for new data and methods innovations. We try to identify all relevant data sources that can contribute to our estimates, and where different groups have studied the same problem using different case definitions or different methods, we try to identify what those differences are, systematically measure the bias between the different approaches, and make adjustments to the data prior to entering them into models, so that we're comparing like with like. We try to identify errors in original data and correct them where the data is available to do so, and then pick the best model based on performance. HCV-related mortality in the GBD is sometimes a little bit hard to find for some collaborators, the way that they're presented in our results, because we estimate hepatitis C related cirrhosis as part of our cirrhosis estimates, liver cancer due to hepatitis C as part of liver cancer, and then also make a separate estimate for acute viral hepatitis. It's all in our visualization tools, but sometimes you have to look across those 3 areas. This year we have produced some summaries and write-ups that aggregate those results for the reader for the first time. And I'm going to go through our modeling process in that order. I'm going to talk about how we first estimate all mortality due to cirrhosis of any cause, and then also estimate the proportion of cirrhosis that is due to chronic hep C as a separate modeling endeavor, and then multiply the outputs of those 2 models to get our estimate of mortality due to cirrhosis due to hepatitis C. Likewise, we make a single, what we call parent model for primary liver cancer, where we estimate all the liver cancer deaths, and then separately estimate the proportions due to each and multiply. And then we have a similar process where we estimate all of our acute viral hepatitis deaths and then assign those to specific virus types. And I'll explain some of the advantages of this as we go along. I'm going to start by describing all of the parent models, so how we estimate mortality due to cirrhosis in its entirety, due to liver cancer, and due to viral hepatitis. Note that when we estimate health loss due to hepatitis C or to hepatitis B, we're only estimating hepatic manifestations. We're not estimating the morbidity due to chronic neuropathy or some of the extrahepatic manifestations, or kidney disease due to hep C or so on. So our cirrhosis mortality uses data inputs that are mostly from vital registration data and some from verbal autopsy data. And these data are distributed across many countries on the map. Here showing gray are countries where we have no data, blue have data, higher intensity means more data, and as you may anticipate, we have less data available in sub-Saharan Africa and some other, and South Asia, North Africa, and the Middle East, Oceania. So our estimates there are informed by predictive covariates and modeling assumptions to a greater extent. Our liver cancer database, or the input data for our liver cancer estimates, also come from vital registration data. There we also have cancer registry data. Many of the cancer registries report on both cancer incidence and mortality for specific cancers. Some only report the incidence of new cancers, and the cancer team separately models a mortality to incidence ratio using the registry data that have both measures included. And then they use our estimates of the incidence of liver cancer to then infer a mortality data point from cancer registry data that only reports incidence, and uses that as an input to the mortality models. And they also have some verbal autopsy data available. The coverage, the data coverage is similar for liver cancer estimation overall as for cirrhosis. And then for acute viral hepatitis, again, we use vital registration data and verbal autopsy data with a similar coverage to the other two causes. All of the data for mortality modeling are prepped by a central causes of death data processing team that specializes in understanding and processing vital registration and other cause of death data in consultation with the modeling teams that are responsible for specific diseases or injuries. And some of the key, there are many, many steps to processing the data, but a key thing to understand here is all of these data sources are reporting an exhaustive set of causes of death for a sample of deaths, or for all deaths in a community, depending on the source. And those data are extracted as cause fraction, so a count of all the deaths in that data set that can be mapped to, for example, cirrhosis, out of all of the deaths reported in that sample. And that's extracted in age groups that are 5 years wide, separately for males and females. Sometimes some of the data sources don't provide that level of granularity, and so assumptions have to be applied from other data sources to impose an age and sex distribution on those data. And in other cases, they're individual level data and they're aggregated perfectly to those sex and age groups. There are some steps to correct common misdiagnoses, although that is a small component of the processing. And then garbage code redistribution, which I think is becoming a more widespread method and a more widely known method, but is not used everywhere. This is one of the reasons why our vital registration data as processed may look different from vital registration data reported by other sources. When we receive a data source with a exhaustive list of causes of death, sometimes the causes given for some of the deaths are implausible, such as a death due to acne, or they are vague, or they are part of the process of someone's death, but we regard them as intermediate or immediate causes of death and not proper underlying causes of death according to ICD sort of instructions and for assigning underlying cause of death. And so we use a number of methods to determine the best distribution of the what we call garbage codes that are vague, implausible, or intermediate, to assign them to the most likely underlying cause of death. And then we redistribute those to the GBD causes that they apply to. There's also some steps of noise reduction and application of a small non-zero floor before these go into our model. The thing that I want to highlight most here is the step of garbage code redistribution, because it's had the probably the largest effect on results for hepatitis C related mortality this year as compared to other years. So here's an example. This diagram shows that for a set of cause of death data from Portugal in 2013, there were a number of deaths that were assigned hepatic failure as the underlying cause of death, which we regard as an intermediate. We redistribute those to the underlying cause of death based on either a proportion observed in the deaths for which we do have a valid underlying cause of death. So the cause of death team with clinician input would decide the potential targets that hepatic failure could redistribute to, and we would look at the proportion, the distribution of those causes of death in the codes that were actually assigned, and then redistribute hepatic failure proportionately to each of those causes. Sometimes that approach doesn't work well for causes, perhaps if there's a taboo or other systematic reason for underreporting certain causes. So we actually use regression methods to predict what the appropriate proportion should be. And increasingly, what we're able to do is use data sources for which we're provided not only what was written as the underlying cause of death, but what was entered by the death certifier in all of the blanks on the death certificate. So then we can say for all of the deaths that were assigned hepatic failure as the underlying cause of death, if we look in the other fields on the death certificate, how often do we see what we would consider to be a more valid underlying cause, and use that to decide the proportion of hepatic failure to assign to those causes of death in the data for which we only have one diagnostic code for the underlying cause of death. Once all of the data are processed for all of these parent models, these models of cirrhosis in its entirety, liver cancer in its entirety, or acute hepatitis in its entirety, we use what's called the causes of death ensemble model, which is a tool used for the majority of causes of death estimated in GBD. It starts by developing a diverse set of individual models to capture known associations. So we specify that from outside sources, there are particular covariates that we know are associated with the cause of death that we're looking at, and give that list to the algorithm. We prioritize them, and then a set of different regression models are made that combine the covariates in different combinations, and test for which individual models have statistical significance and have associations with covariates that are in the expected directions. So a model would be rejected if it found a negative association between death due to hepatitis C, for example, and injection drug use, or if it found a negative association between cirrhosis in its entirety and alcohol. These models can be formulated as models of the logit cause fraction or of the log mortality rate. And the mixture of model types include linear mixed effects models and spatiotemporal Gaussian process regression models. Then all of those individual models are assessed for their out-of-sample predictive validity. And then the algorithm evaluates differently weighted combinations or ensembles of those individual models to find the combination with the highest out-of-sample predictive validity. In GBD 2019, the changes to the cirrhosis models, liver cancer models, acute hepatitis models included adding just additional years of data, and additional both for the cause fraction and also for the covariates used to predict. We also changed our method of estimating covariate relationships so that very small population countries with very unstable data don't contribute to estimating the size of the covariate relationships or they don't go into estimating those coefficients. Only the countries with a minimum population size contributed to that part of the modeling. And we also made changes in how we mapped ICD codes to GBD causes and to garbage code redistribution. And this is probably what had the biggest impact on our HCV-related mortality this year. One of these changes was that for liver cancer, in previous rounds, ICD code C22.9, which is malignant neoplasm of liver not specified as primary or secondary, was mapped directly to liver cancer as a GBD cause of death. Acute there are a number of ICD codes that we consider garbage codes that are hepatitis unspecified that were previously mapped directly to acute hepatitis. Review of multiple cause of death data showed that many deaths coded as hepatitis unspecified had cirrhosis or liver cancer or some other chronic sequela of infection in the causal chain. And so we started redistributing the hepatitis unspecified deaths between cirrhosis, liver cancer, and acute hepatitis. And then based on a large systematic review, the cancer team determined the proportions that they would like the C22.9 deaths distributed to based on the most likely primary cancers to have mets to the liver, as well as primary liver cancers. So the result of that in GBD 2019 is here's again a map where along the left-hand side we see a bar representing the number of deaths that were that had as underlying cause of death primary or secondary liver cancer unspecified, this C22.9. And there were, for Poland in 2013, 377 deaths with this assigned as the underlying cause of death. Where they had previously been mapped directly to liver cancer, they now map a proportion of them to colon and rectum cancer, a proportion to stomach cancer, to pancreatic cancer, breast cancer, prostate cancer, et cetera, et cetera. And we see down here that the number mapped as primary liver cancers is a small fraction of the total. There were similar changes with acute with hepatitis unspecified codes, which previously mapped directly to acute hepatitis, and now largely mapped to cirrhosis, with a smaller number mapping to acute hepatitis B or hepatitis C, and in some locations, not apparently this particular year in Poland, also to hepatitis A and D. That resulted in changes in the number of deaths estimated due to liver cancer, as well as smaller changes to the number of deaths estimated for cirrhosis and acute hepatitis between GBD 2017 and GBD 2019. So here I'm showing death counts for the entire world estimated for the year 2017. And in GBD 2017, with the addition of some new data and with some hepatitis unspecified deaths now being remapped to total cirrhosis, we saw an increase in the number of deaths that we estimated were due to cirrhosis. It's not a huge percent change because cirrhosis is a very common cause of death and has and a large number of the deaths are actually coded as cirrhosis as the underlying cause of death to start with. In the case of liver cancer, where we removed what we think were a large number of other primary cancers, we saw the total number of liver cancer deaths estimated drop almost by half. And then acute hepatitis deaths also decreased primarily by being redistributed to cirrhosis, but it has a larger proportional effect on acute hepatitis, which is a less common cause of death to start with. So now that I've described how we come up with our total estimates of cirrhosis mortality and liver cancer mortality, I'm going to talk about how we estimate how much of that to attribute to hepatitis C versus some other cause of cirrhosis or liver cancer. We use as our data inputs case series reports published in peer-reviewed publications. They need to be representative cases of cirrhosis without liver cancer. We take data from 1980 onwards, and all of these report the proportion due to one or more of the etiologies that we estimate in GBD: alcohol, hepatitis B, hepatitis C, cryptogenic, and or NASH. They may report some additional etiologies which we would map to other causes. So we extract all of these proportions. And when we do that, we require that these studies have confirmed the cirrhosis cases that they're attributing to hepatitis C with serology, not necessarily with confirmation of viremia, but at least with an anti-HCV IgG. The data for this portion of the modeling process are far less robust than for estimating the parent models for the overall burden of cirrhosis. You can see here many more countries that are gray and have no data, and many of the countries with data, many more are sort of a light blue. Sometimes this is because the lighter colors are due to having fewer studies from a location as compared to a more intense location. And sometimes they represent having the same number of studies, but in one location, we were able to extract more rows of data because the data were reported with finer age specificity or sex specificity. So there were more total rows of data coming into our model. And required less processing. The modeling tool that we use to then estimate the proportion and fill in estimates for all of these gray locations is a tool called the Disease Modeling Meta-Regression Tool, or DISMOD-MR. It's the tool that's most often used for estimating non-fatal disease measures in GBD, prevalence and incidence and so on. But here we use it to estimate a proportion. It's a mixed effects meta-regression tool that uses an offset log normal data likelihood model. It estimates fixed effects for age and sex and for predictive covariates that we select, such as injection drug use, sociodemographic index. And then it estimates nested random effects for all of the locations. And we talk about it as if it were one model, but it's actually a series of many models. We separately run models for different years spread out by 5 years in time. And then once we get the final results for each year, interpolate between them for the intervening years. And then we also use a series of preliminary models that serve as Bayesian priors for subsequent models down over what we call our geographic cascade. So we start out using all data for all locations in one large mixed effects model, our global model. And from that, develop Bayesian priors for 7 distinct models for each of our GBD super regions. Those super region models only use data from that super region and have the opportunity to modify the prior predicted from the global model. Those then serve as the Bayesian prior for regional models for smaller geographic units. The regional models serve to produce a Bayesian prior for country level models. And then for some countries, this goes on to the subnational level. And then once we have what we think is the best model at the most granular geography, those are aggregated back up to so that what's actually seen in the publications, what we report as the global burden, is not based on that original model, but based on aggregating the results of all of the finest level models. Things that changed in our proportion models in GBD 2019 as compared to GBD 2017 were less major than our changes in our parent models for cirrhosis and liver cancer. So for cirrhosis, we added additional case series data, and then also the covariate that we used to help with the predictions in that model, which is a measure of anti-HCV seroprevalence, that also was updated with additional data. The liver cancer model actually used the exact same data and covariates in GBD 2017 and 2019 for estimating proportions, and only updated the parent model inputs and methods. So this resulted in small changes in the proportion of cirrhosis attributed to hepatitis C, but fairly stable, 26% in our previous round of estimation, 27% in our current for the year 2017. And then identical proportions for the liver cancer, but of course, that proportion is now being applied to a much smaller total liver cancer estimate, so that there were a much smaller number of deaths estimated for liver cancer due to hepatitis C in GBD 2019 than in GBD 2017. For our acute viral hepatitis estimates, we don't use a proportion method. We run a parent model for all acute viral hepatitis deaths, as I described. And then we used to, in GBD 2017, then use case fatality ratios from hospital data that reported on deaths by virus type. Which was a small data set of about 16 sources. So we'd extract all of the cases, all of the discharges with those virus-specific acute hepatitis deaths, the fraction of them that died, and then model those case fatality ratios separately for each viral type. And then apply those case fatality ratios to our incidence, the estimates for the incidence of acute viral hepatitis due to each virus type that we were producing at the time, and use that to that would produce an estimate of deaths that we would then scale to the total from the parent model. We thought this was unlikely to, we thought that case fatality ratios of hospitalized patients were a very poor representation of the case fatality ratio in the community, and that the 16 hospitals for which we had this very specific kind of data were poorly representative of the worldwide distribution of different virus types and their case fatalities. So we abandoned that method in GBD 2019 and actually ran cause of death ensemble models, CODA models, for each specific viral type as well. This was facilitated by having some high quality vital registration data from a subset of countries. We left out data from countries with highly incomplete or vital registration, and leaving out verbal autopsy data, leaving out data that were heavy on garbage codes. Just use the 4 and 5 star quality data that we have in our cause of death database. And then we were able to use the cause of death ensemble model for this purpose for the first time because there was an update to that tool where, in addition to testing models that were based on a log mortality rate or a logit cause fraction, we were able to have some of the candidate models to go into the ensemble be count models, which were heavily selected for this rare cause. We then scale the virus-specific deaths to the acute hepatitis mortality envelope. The data inputs for that are shown here. And then the result there of the two changes, our estimates of all acute viral hepatitis deaths are lower because we're now redistributing garbage codes for unspecified hepatitis to both cirrhosis and acute hepatitis. So we see a large decrease in the number of cases of or deaths due to acute viral hepatitis across all virus types. But because we also changed our method for determining how many of those to attribute to hepatitis C, we actually saw an increase in the number of those deaths that we attributed to hepatitis C now that we're actually using vital registration data and cause of death ensemble model rather than this hospital case fatality based method that we used previously. So we see a small increase in what is still a rare cause of death, less than 5,500 globally. So to summarize those changes, our total cirrhosis deaths increased slightly, largely due to changes in garbage code redistribution. The proportion that we attributed to hepatitis C increased very slightly, mostly just due to new data. Our liver cancer death estimates went down considerably, we believe due to a very appropriate change in garbage code redistribution, acknowledging that a large number of the deaths coded as C22.9 are actually METs from other primary cancers. And we had a stable proportion that were attributed to hepatitis C. And then we had a decrease in acute viral hepatitis deaths overall due to changes in garbage code redistribution, but a slight increase in how many of those we attributed to acute hepatitis C, we think based on a more robust set of data inputs because we were able to use vital registration data from many locations as opposed to hospital data from only 16 locations. So overall, a small decrease in our estimates of HCV-related deaths, which I wrote out in text in my next slide, but I've already talked through while we were looking at the numbers. Some of our future plans are to continue updating our data inputs, including our routine updates to vital registration and seroprevalence data, and a much larger body of a new etiologic proportion data from an soon to be published systematic review that we're aware of from some international collaborators. We have started thinking about whether it would be possible to make some new data collection efforts given that etiologic proportions from case series do not necessarily have the same demands for complete coverage and intense surveillance that mortality rate data do. We also would like to incorporate a new predictive covariate into our cirrhosis mortality models. we last year developed a chronic hepatitis C model where we start with our seroprevalence model, which was used in our mortality estimates, but then adjust to estimate the proportion of seropositive individuals who are viremic based on 42 direct comparisons of these measures in the pretreatment era. And then we also now have data that we can use to then remove viremic cases from our estimate of chronic hepatitis C based on treatment campaign data from 26 countries, which became available to us largely through the efforts of CGHE, exclusively due to the efforts of CGHE, and we're very grateful for that. And then we have some ideas about how to reevaluate how to assign virus type specificity to our acute hepatitis estimates as well. That is the overview of our mortality methods for hepatitis C, and I'd like to open it up to questions, conversations, comparisons.
Thank you, Meg. Very helpful. I know Meg Doherty has joined us. I know it's late. Meg, if you want to say a quick hello or any other comments you have.
Oh, well, thank you. It's quite late here, but it was just very interesting, and it reminds me of my days of way back when I was doing modeling and using SAS. So the only question I really had is why you're fixing. Anyhow, there seems to be so many intricacies to the model that I would probably have to read it a bit to understand, you know, what that junk means and how that really had an effect on decreasing mortality. But around the fixed and the random effects, I have some questions, but probably not for now. It's just more of interest. Lastly, I'm not sure I fully understood how, you know, what the data is going in and how confident we are with all the data going in. But I know there was quite a bit of explanation, so I think it's more that I just would have to sit down and and understand and maybe read through the data to understand how confident you feel the data are on which you're building this model, because as you mentioned earlier, it's so difficult to find the vital registrations around some of these estimates and these data in country. But thank you. It sounds like very complex and incredibly useful modeling, and I probably just need to get a bit more understanding over time. But there are other people from WHO who are on the call, which include Fumi Leshi, as well as I think I saw Fusheng, and I think I saw Philippa working quite closely with Greg Dorr on understanding for our development of criteria for validation of elimination, and that's coming up next week. So maybe anybody else on the phone call could sort of make a link for me between this work and the work that we will be discussing next week, and maybe that could be either Philippa or Greg as well. Thank you very much.
Thank you, Meg. Thank you.
So, Meg, to your question about our level of confidence in the data, what I will emphasize is that the quantity and quality of the data that we can use to estimate mortality due to cirrhosis overall, and due to liver cancer overall, and to acute hepatitis overall, is far greater than the data that we can use to estimate what proportion of those are due to chronic hepatitis C infection. And that is, it's a limitation, but by the same token, it means that we're not resting our entire estimation process on the ability of a sort of a routine vital registration system to accurately capture the etiology of the cirrhosis or liver cancer deaths that are recorded. And so we feel like using that strength for the parent models or the overall models gives us a good basis, and that the more that we can obtain case series data, the better our attributions will be.
John, it's Greg. Can I make a couple of comments or ask a couple of questions as well? I mean, obviously the 22.9 redistributions, kind of the big change from the previous sort of round. And we're going from a situation where around 40% of all Hep C related liver deaths were thought due to HCC down to 26%. So the question is that 26% sort of the right ballpark? Is it a bit low? Is the cirrhosis deaths a bit inflated? Because I think you've probably got a better handle on the HCC now. I mean, completely agree with the need to redistribute 22.9. Yeah. So that's the first sort of question. Second, related to that is how the messaging is going to go. So overall, we're going to see a 9-10% reduction in Hep C related liver deaths, but the cirrhosis deaths have gone up 15%. Liver cancer deaths have gone down 40%. Almost certainly, I think there's been an increasing burden of Hep C related liver deaths globally, and it's probably more than the 15% that we're estimating. So that messaging will be a little tricky, I think, in how we sort of deal with this going forward. The other question is around the sort of confirmation of Hep C. I'm trying to get to the real sort of nut of what that proportion is, and sort of going forward, and it's something we're dealing with the background paper, is are you going to try and distinguish between forever chronic infection versus currently sort of viremic cases, and how that will be dealt with sort of going forward, because hopefully it'll become a bigger issue as we cure more people.
Yeah. Yes. In terms of whether or not the 40% versus 26% is now in the right ballpark, you know, I think, you know, I think we had a good solid rationale for the change that produced the expected change in estimates. As you said, the redistribution of C22.9. How that compares to how the final results then compare to other estimation approaches is sort of the next phase of decision making. I wasn't sure when you were talking about the overall increase if you meant a change in estimates from previous estimation efforts, or if you meant an increase in mortality over time.
So there'll be an overall reduction, but cirrhosis will go up by 15%. Yeah. And you would think that if you are accurately gauging cirrhosis, then the overall burden should be going up. It's just that you've redistributed the 22.9. So are you going to go back to the previous round and work out what it would have been if that redistribution had been done, and factor that in, and then say, actually, this is the overall change that we've seen over the last sort of few years, based on a different methodology?
So we've re-estimated the entire time series, and I'm sorry, I only presented the results for the year 2017 as estimated in GBD 2017 and in GBD 2019, but we have estimates from 1990 through 2019 with the new method.
And presumably that just shows a steadily increasing, burden of Hep C related liver deaths.
Yes, let me pull up a time trend in our visualization tool.
Again, I think that's important in terms of the overall messaging, to be able to show that sort of figure, rather than this sort of reduction over the last sort of few years by 9%.
That is one way to reach a global elimination goal.
Exactly. Exactly. It's like homie reducing the viremic prevalence.
Hey, we'll do it. We'll do it. We'll take whatever we can get.
But John, it is actually important when we think
It
about the comparison to 2015 and what the 2015 figure is going to be in terms of viral hepatitis deaths. It may not. Clearly, it can't be 1.4. If we factor this in, it's going to come down somewhat.
It will.
Yeah. So our
So I don't know. Can you find that, May, or should we?
So our percentage change globally in deaths between 2010 and 2019, taking both cirrhosis and liver cancer into account and using the same methods across all years, is about a 17% increase in deaths. And
it'd be good to produce a figure that just shows that curve and shows that it hasn't sort of dipped down at all in the last sort of like couple of years. There's just been this steady increase over that period of time, which I imagine it is.
Yeah.
Philippa has a question in the chat. I don't know if you want to look at that, Mayor.
Yeah, let's take a look.
If you can look at that, what's the role of the IHME data in supporting individual country level validation or trends in mortality? Using your modeling, and then also variability in country level, the quality of country data across countries. How do you factor that in, where you may actually have better data to show that proportional attributable fraction varies for hepatitis C, and do you get to that level of detail?
Yeah, so, I mean, I think that individual countries that are tracking their progress towards elimination can use the time trends in IHME data to identify sort of the whether or not they're on track, but not to but more for the purpose of then planning the right confirmatory studies for their own local context. For a country where we have literally no data on cirrhosis mortality or liver cancer mortality, there's no vital registration, there are no case series data, there are scant or no serology data, I think some primary data collection would be in order. But I think with this approach and with the strength of the predictions for the parent models, it potentially could be reasonable for countries to target specifically collecting case series data, specifically collecting seroprevalence data or treatment data, some of the indicators that feed into the model, because for the parent models, for some locations with no data, like vital registration data, the predictions are pretty strong from neighboring countries with viral registration, strong relationships with covariates. So I think there could be cases where we have no vital registration data, but we feel pretty good about our cirrhosis and liver cancer estimates overall, and we would only need to collect data on some of the specific parameters of used to estimate the proportion due to hepatitis C.
Yeah.
We also have, for many countries, estimates at the subnational level, and variations in those could highlight, if we're going to collect data in one subnational location in one district, where is the sort of the worst case scenario where we know if our data come back reassuring there, that we're probably can have high confidence in other areas as well. So I think both geographic targeting and the choice of indicators could be guided by the modeling.
Okay. Yeah, I know in our conversations, Greg can comment on it, talking about how modeling could give you some kind of presumptive estimation of achievement, and then that would drive you toward a more precise study to document and verify the achievement of a goal. And then lastly, quickly, about like in a country like the United States, like you just look at the CDC surveillance reports, 23% decline in HCV death rate between 2015 and the last reporting year. How would that data be used or not? Because it looks like you start with cirrhosis or liver cancer and then go down versus just a direct estimation of hepatitis C or hepatitis B, mortality rates in the case of the US. So.
Yeah, so in terms of producing the models, it's true some of these high quality surveillance systems, those data don't enter into this estimation process, but I think they're an excellent way to validate and tune the parameters on the model. I would contend that there may be some extent of, if cases are missed in a surveillance system, they still show up in vital registration, and we make our best estimate of where to assign them. So I think that there's probably better coverage. We're making our best guesses of how many of the people who died supposedly of hepatic failure, who probably didn't show up in a surveillance system, what fraction of them do we think died of hep C cirrhosis? But if we have very different numbers, very different trends from a high quality surveillance system, then we need to go back to our data inputs and choices of covariates and reassess whether our model is appropriate.
John, the data that you're talking about in terms of that decline, that's vital registration data, isn't it? I mean, the US uses...
it's mortality data. Yeah.
I mean, Australia, we've got linkage-based data, and we sort of look at that as well as vital registration data. And there's about 30% in the vital registration that don't have mention of hepatitis C that we know through linkage. So there's always an issue with sensitivity. It's the trends that's important. As long as the system's stable, it's fine. But just getting back to, again, that sort of 26% that I'm a bit sort of nervous about, total sort of deaths that HCC related. I mean, it might be worth trying to get sort of countries that have got good quality data around that, around the split between HCC and sort of liver failure based liver deaths. I mean, we're about a third HCC and 2/3 cirrhosis in terms of our breakdown for hep C related liver deaths. And there must be a range of countries where that quality of data in terms of that proportion is pretty solid. And look, it's going to vary if you've got different comorbidities for cirrhosis versus HCC, it will vary somewhat. But it shouldn't vary hugely, I would have thought, unless there are specific cofactors for HCC or cirrhosis of different in different sort of settings.
Yeah.
And just getting back to that issue I asked about the confirmation of hep C, what do you think you'll do going forward? Will you include people that are ever chronic? The case series presumably will be very varied in terms of how they attribute a hep C related sort of case even in terms of active infection versus past infection.
It's a good question. Yeah. We haven't had the good fortune of having to deal with yet, but we will. We could.
I don't know the answer.
Yeah. We could potentially, estimate proportions of cured, but due to hep C, and proportions with active hep C, and estimate separate proportions. I think that would require quite a bit of good data to come up with a good estimate. But
I I think it is complex because I think cured Hep C and HCC risk in people with cirrhosis is very different to cured Hep C and decompensated cirrhosis death risk. I think cure really reduces the decomp sort of cirrhosis risk markedly, but decreases the HCC risk moderately. So it's quite different.
Yeah. Well, and those the cirrhosis versus HCC proportions are modeled separately already. So we would presumably take a different approach for the two diseases given the longer lag time on the HCC.
Sway, Philippa, I think, Homie, do you have any comments?
Yes, thank you, Jian. This is a great presentation. And, you know, I saw that a big proportion of the country without any data based on the coverage of the data map. And we do know that for those countries with data, either, you know, the cancer registry, service prevalence, or any other, you know, the source of the data, we can do any analysis for sure. But for country without any, you know, information about the data, so how can you handle this country without the data? You mentioned about the communication process. I don't know for those countries, have you gotten any input from the member states? How confident about this data for the member states? Over. Thank you.
So you're asking about communication with member states about their mortality data?
Mortality and the acute incident data.
Yeah, so I mean, a large proportion of the data that we use in our models is provided through engagement with collaborators from the countries for which we make estimates. In the case of vital registration or verbal autopsy data, it is true that there are many countries with no data whatsoever for the mortality. We've had more limited interactions with with collaborators who have access to case series data. Where we've had the strongest collaborations and the most data sharing is actually with regard to HCV seroprevalence, where I actually didn't show the data coverage map for that. I think I have a copy of it available. But there we have much better data coverage and also a lot more interactions with people who are conducting serosurveys and serologic monitoring. So I'll just briefly take this screen back and show our data coverage maps are quite different for serology, where we have actually less data in our sort of high income countries overall, but somewhat better representation in sub-Saharan Africa and South Asia, and in China in particular. So.
Okay. Other comments?
Do you mind if I ask a quick question?
Mm-hmm.
As always, a fantastic job. It's just it never ceases to amaze me the amount of work that goes into developing these estimates. And of course, this is done annually. So when you step back and look at the big picture, do they make sense?
What do you think?
Well, so treatment has been going up.
Mm-hmm.
Now we do know when with treatment that they do, when people achieve SVR, the progression to cirrhosis, if they're fibrotic, just stops. If they are already cirrhotics, that it slows down.
Mm-hmm.
So, and there's, data from US, Australia, a number of other countries shown that in fact mortality goes down as a result of treatment. So increased treatment has increased SVR. So without modeling, I would say as treatment went up, we should have seen a reduction in mortality. Is that what comes out of the models? If we look at longitudinal data between 2015 and 2019, does mortality actually go down?
The mortality rate in the population?
Hep C, yeah, Hep C related mortality, whether it's due to cirrhosis, HCC, or acute. So what you showed was a 2017 versus the most recent update, but that's the overall. There's the trends buried in those. So if we look at the global, if we use the latest estimate and we look at the global trend between 2015 and 2019, do the total number of deaths goes up or down?
It depends on where you are.
Globally.
Goes down only because of the redistribution. But I mean, Homie, you wouldn't expect, I mean, the treatment uptake globally has still been very, very low.
Very, very meager.
I mean, I wouldn't have expected any change in the global burden. I mean, we've been steadily increasing. So to get that to sort of turn around and start to go down would take a much bigger treatment uptake than we've had in the last sort of 3 or 4 years. So we know the HCC is a bit delayed in terms of the impact you have in terms of treatment. Even in Australia, we've had a nice sort of turnaround, but we're one of the few countries that's had really good treatment uptake. So if it hadn't been for
got treated in 2019.
Yeah, but globally, how many globally have you got that have been treated since
2.7 million? 2.7 million out of 60 million. That's pretty acceptable.
7 million, did you say?
No, so 2.7 million out of 60 million infections.
It won't have an impact. I mean, it's a tiny proportion, 5%.
Especially for those who already have advanced fibrosis, for people who already have they've already had cancer at the time that they were treated, and then you only have like, a few percent treated. But there are countries that are starting to see an impact, but not at the global level.
Yeah, I mean, this is always the challenge with modeling, isn't it? There's a lot of intricacies, a lot of data that goes into it. I think, we always need to step back and look at the big picture and say, all right, do the trends that we see actually makes any sense? So do you see a sharp reduction in Australia and the US, as the data suggests?
Yeah, but we're a tiny proportion of the Hep C population globally.
I think this is I mean, if you just, it's sort of like Homie's just extending, I think, the thread of the questions from Philippa and Swei-Fu Chang, which is, what's the responsiveness of the modeling to the country, the variability across countries, not just in the trivial fraction of the cirrhosis quality of our registry data, but also the treatment data that you touched upon, May. I mean, are you sort of gearing up to begin to put that data into the model so that you can really, okay. Go ahead.
I mean, even in the GBD 2019 estimates where we don't have the treatment data explicitly worked into the model, we do see declines between 2015 and 2019 in mortality rates just based on primary data for the USA, Australia. But they're small declines in the mortality rates in large countries, but not, the majority of the burden worldwide. And then with, when you translate that across the entire world, we still have like a rising mortality worldwide. we have like a decrease just based on primary data about deaths in Australia and the US. It's on the order of like 5% of the mortality rate space.
So Jaime, you could model it going forward, so to speak, going the other direction, and tell us what your models would have predicted, given the treatment uptake, that we should have changed the mortality between, say, 2015 and 2019. You could do that from your end, and it would then be interesting to compare your estimates of change to what IHME get once they sort out that 22.9, once they adjust for that. To see how they would compare in terms of those trends.
Yeah.
I think we have that country by country in the tables that we prepped for the working paper, right? For specific countries. We don't have the global numbers in those tables, but we could certainly add them in.
Yeah, and I apologize. I didn't mean to suggest that ours is correct.
No.
I'm saying that comparison would be interesting. I think it would be to look at that comparison.
Given what treatment's been applied and what you model about the effective treatment, what should we see? And then based on our vital registration data and adjustments for treatment, what do we see?
Okay. Yeah, that might be a good exercise to do. I know we're a little over time. We'll go another 5 or 10 minutes, I guess, but I want to get to Fumi's questions because they're both related to Africa and the quality of the data there. So Fumi, do you want to ask those if you're still on, please?
Yeah, thank you very much. And I must thank May for the excellent presentation of great complexity. In all the presentations she showed, I noted clearly that there's a huge gap in an entire continent. And the question is really, what is the confidence of the data where an entire continent has no data?
It's low for that continent relative to the other locations. The strongest part of the modeling in sub-Saharan Africa is the or in the Afro region, depending on how we divide up the map. But the strongest data component there is the seroprevalence data that's used as a covariate. To the extent that the seroprevalence has a strong association with HCV mortality in the cirrhosis and liver cancer models for those locations where we do have vital registration data. We get some predictions based on seroprevalence that we think are good as predictions go, but they are all based on what is the relationship between seroprevalence and death in other locations, and then what are the measured data for seroprevalence in these countries in Africa. Ideally, we would love to have better primary mortality data from all of the countries where we don't have them now. I think depending, some of the tractable data collection efforts would be around some of the indicators like case series data, which I think we've talked about before and have some upcoming plans to talk about how to get more of those. But to actually have the primary mortality data for the approach in GBD, we need comprehensive reports of all the deaths in a community, not just HCV. And that's a vital registration system. So that is, I guess, one downside of this is that as compared to a focused surveillance effort to just track HCV deaths, getting vital registration data is a larger enterprise. But I guess those are the trade-offs. The case series would be helpful.
Fumi, do you want to make your second point, please, from the chat about from your experience in Africa about the overestimation of HCV?
I think she's addressed the whole issue of poor data. So there are estimates.
Yeah, thank you.
Yeah. And you directed us towards some studies in the last meeting that had information on etiology of liver cancer that we're following up on to try to see if we can add those to the models. So I appreciate that.
Okay. Any other comments, questions?
John, just to congratulate May. I mean, it's an amazing amount of work, and it's great to have this opportunity to see it presented. And given that we're sort of heading into the workshop next week, just perfect timing to help sort of shape some of that discussion as well. As I said to John, I'll be involved in the discussion early in the evening. I'll be handing over to you guys to sort of take on the robust discussion aspect of it.
Come on, if Philippa and Fumi can stay up to this hour, surely you can take one. But anyway, this is really good. I thought it would be helpful. I really appreciate May outlining these changes so we can better understand it. She can hear feedback from us. She's part of our larger team now, and I really I think it's really been helpful. So thank you very much, May.
Thank you.
And if you have some follow-up questions, I'm sure she'd be happy to entertain them. We've recorded this. Can we share your slides, May? Is that okay with the group?
Yeah.
Okay, so we'll do that as well. So thank you all.
Thanks, John.
Okay, good to see you.
Very much.
Keep in touch. Okay, take care.